Welcome to the volunteer training program organized by Palliative India. Just a heads up about the basic rules. Participants should attend at least 4 sessions live to become eligible for the final certification. And we strongly suggest all participants to keep their videos on during the session as of possible. Like few will have connectivity issues. If there is no connectivity issues, you can switch it off. Switch it on. Otherwise, you can keep it off. Please use the chat box to post your queries. Wishing you all a successful mutual learning experience. Now, entering to the formal session, uh, let me take this opportunity to introduce the topic and the faculty for the day. We are going to have a session introduction to palliative care, and for that, we have one of the eminent faculties, Dr. E. Divakaran, sir. He completed his MBBS in 1979, DA in 1985, and he is an MD in anesthesiology. He did it from Calicut Medical College, Kozhikode. Um, he did his training in palliative care from Medical College, Calicut. He has served as founder secretary of Pain and Palliative Care Society in Thrissur. He's the director and faculty at IPC, Institute of Palliative Care in Thrissur. He is faculty at Institute of Palliative Medicine, Calicut from 2003 onwards. He has published an article in the European Journal of Palliative Medicine and a narrative in Journal of Pain and Palliative Pharmacotherapy. He has co-authored an article in Indian Journal of Palliative Care. Welcome, sir, to the session. Over to you. Thank you.
Good evening. Good evening, everybody. Can I share the screen?
Sure, sir. Yes, sir. Now you can do.
Okay. Is it? Can you see that screen?
Not yet, sir.
I don't know what happened. Now, is it visible?
If there is network issues, it might take some sound. Some time. Yeah, now it's set. Yeah.
Okay.
Sir, it's the desktop that we are seeing. It's not the presentation. If you are showing the presentation. Yeah, now it's okay.
Okay.
Yes, yes.
Yeah. So today's topic is introducing palliative care. Now, I wish to present my presentation under the following headings: the need, why palliative care, what is the need of palliative care. We have been practicing medicine for such a long time, and now only we have started talking about palliative care. What might be the reason? And another thing is about the history. How did palliative care came into being, and how did it develop into the present day palliative care? Then the philosophy behind the care philosophy behind palliative care, and how we define palliative care. Palliative care, the concept of palliative care has undergone several changes during the course of the development of palliative care. So we'll see how the present day concept of palliative care came into being, and what are the models of palliative care delivery, and a few words about the recognized medical institution, the concept of recognized medical institution, which is very important for purchasing and storing oral morphine tablets. Now, about the need of, actually, we know that palliative care is something to address the suffering of the patients. Why did the mainstream medicine fail to address the patient suffering? Why do we have to invent this palliative care medicine as a subspecialty to address the suffering of the patient? That's the question. The reason is that mainstream medicine approach is disease focused. I will explain, because there are two things: illness experience of the patient and the disease. Illness experience of the patients experience of the ill health. It has got a lot of component. It has got physical issues. It has got psychological issues. There's the problem with social isolation, the economic, financial problems, that sort of social issues, and there will be psychological issues like depression, grief, anxiety, a lot of psychological issues, and they may also have spiritual issues also when they uh, face an incurable illness or a life-limiting illness. They will ask ultimate questions of what's the point of it all, what's the meaning of it. That sort of issues are called spiritual issues. So these are the illness experience of the patient. Whereas disease is the structural disorder of organs and tissues that give rise to the signs of ill health. The doctors are more concerned about the disease part of it. So they assume to be the cause of the suffering. Uh, of course, there is some relationship between the disease and the illness experience, but a disease cannot define the whole gamut of illness experience of the patient. So that is the problem. So the symptoms are just considered as manifestations of the disease and is dealt with by treating the underlying disease. That's the attitude of the doctors. The symptoms are just manifestations of the disease. And so the best way to address the symptoms is to deal with the underlying disease. So they are focusing on the disease itself. They are not at all addressing the symptom. That's the problem. The disease-focused approach results in two things. There is one, under-treatment of symptoms leading to unrelieved suffering, because they uh, consider symptoms only as pointers for a particular disease. So they give only that importance, and they think that when the disease is cured or relieved, the symptoms will be relieved. So that sort of approach leads to unrelieved suffering. And another thing is that loss of physician's interest when the disease becomes incurable. They are focusing on the disease. When once the disease is incurable, they have nothing more to do. So they lose interest in the patient. They will say, no, you need not come here anymore. We have done everything possible for you. That sort of, they are abandoning the patient. This is a state of affairs went for a long time, and then we have a reflection. No, this unrelieved suffering should be addressed, and then came the uh, concept of palliative care. And there is the impact of non-communicable disease on health status is steadily increasing. The non-communicable disease are long protracted disease leading to a lot of suffering, which are not relieved by the usual medical model. And there's the growth in aging population. It is said that nearly 45%, that is nearly one half of the India's disease burden is projected to be borne by older adults by 2030. And what is the magnitude of the problem? Out of 1 lakh population, it is estimated, it's a very conservative estimation, at least 400 people will need palliative care for 1 lakh population. And we know that the palliative care coverage in India is an abysmal 2 to 3% only. 2 to 3% of not population, 2 to 3% of those who need palliative care is only getting palliative care. And the 67th World Health Assembly adopted the following things. That is strengthening of palliative care as a component of comprehensive care throughout the life course. That is admonished the member state to ensure that palliative care is an integral component of all relevant global disease control and healthcare system plans, including those relating to non-communicable disease and universal health coverage, as well as being included in countries and regional cooperation plans. So palliative care has to be integrated into the mainstream medicine. That is the concept of World Health Assembly. And our national palliative program in palliative care established in 2012 also said, encourage the attitudinal shift among healthcare professionals by strengthening and incorporating the principles of long-term care and palliative care into the educational curricula of medical, nursing, pharmacy, and social work courses. Now we have uh, a component of palliative care in all these curricula of all these students. In medical, we have incorporated the palliative care topics in MBBS curricula and nursing, pharmacy, and social work. MSW students come to our clinic for field work. So palliative care is a component of all educational curricula. Now, 2017 came the Lancet Commission report. They said that palliative care should be given for all those who is having serious health-related suffering. Suffering is health-related when it is associated with illness or injury of any kind. That's the suffering. Suffering is health-related when it is associated with illness or injury of any kind. And suffering is serious when it cannot be relieved without medical intervention and when it compromises physical, social, or emotional functioning. When the suffering cannot be relieved without any medical intervention, and when it compromises the physical, social, and emotional function, it is called a serious health-related suffering. And palliative care should be focused on relieving the serious health-related suffering that is associated with life-limiting or life-threatening condition or the end of life. Now we know that palliative care should be given for any patient suffering from serious health-related suffering. That is what make a person eligible for palliative care is not the life expectancy or the terminal nature of the illness or incurable nature of the illness, but it is the suffering. If a particular disease is causing a lot of suffering to the patient, the care of the patient should have a component of palliative care. That's the present day understanding about palliative care. Then the history, as a compassionate care, palliative care has got a long history. In Europe, in Western countries, it is synonymous with hospice care. And the initially the hospice, the term hospice doesn't have any relationship with patient care. Actually, they were the centers for pilgrims to spend their night after the weary day-long journey. And there will be some food and shelter for these pilgrims. And they spend the night there, relieved of their suffering, of their tiredness. They resume their journey to the Holy Land the next day. And in 1879, a remarkable lady by name, Mother Mary Aikenhead, she started a Our Lady's our Irish Sisters of Charity by name, and the assignment for the members of this Irish Sisters of Charity was to collect all those patients who are the wayside or in the street, and collect them and bring them to her own home. She provided her own home for that as a shelter, and offer them a dignified death. That was the thing. And when she thought about naming it, this is not a nursing home, or it's not something, it's not a clinic, because patients are not going out relieved of the disease. They are all dying. But according to her, death is not the end of the journey. Journey has to continue. So she remembered she recollected the name hospice. So this is a hospice where patients with their lifelong journey end there, and after taking the rest, they they start their onward journey to the next world. And so the term hospice came into being for the first time as end of life care by 19th century. And we also had a hospice in India, Hospice de Basis de Richmond, started in 1876, run by Sisters of Notre Dame de Bon Secours. So that, but at that time, the modern medicine has not developed so much. Now, how to utilize the advantage of modern medicine for the care of these patients? That sort of a modern hospice was started in 1967 by Cicely Saunders. We should remember this name. We have one remarkable lady. She started her career as a nurse, and then she became a social worker. And at the age of 35 or so, she learned medicine and became a doctor. So a social worker, a nurse, and a doctor rolled into one, and that's her advantage. And she started the modern hospice, the hospice we know now. That sort of hospice. At that time, also there were, and she has given us the care philosophy. That is how we should see our patients, or what impression we give to our patient. That how we are seeing them. Actually, in modern medicine has a reductionist approach of reducing the patients into disease or organs, and we refer these patients as the case of appendix or case of thyroid, etc. We address them as a or we refer them as organs of disease. So the personhood is lost. So Cicely Saunders said that we should not uh, uh, oversee the person behind the disease. We should not forget the person behind the disease. So we should address these patients as the person, the unique individuals, and this has to come through our actions, words, and our body language, etc. But when you put it into a words, it will be something like that. You matter because you are you. You matter to the last moment of your life, and we will do all that we can, not only to help you die peacefully, but to live until you die. This is that. You matter because you are you. You may be your health condition may be very bad, and the patient might have lost his personality as such, but he is still important because he is a unique individual. He is irreplaceable. That uniqueness and innate value of the person we are recognizing. So that's the meaning of you matter because you are you, and you matter to the last moment of your life. The fact that their life is ebbing out doesn't lessen the importance of their life. And we will do everything possible for these patients. Uh, and we will do all that we can, not only to help you die peacefully, but to live until you die. That's the message we are giving to these patients. Actually, the concern of palliative care is not about the death. It is about the life they are leading and how to make that life livable. That is the aim of palliative care. And then the term palliative care was introduced by Dr. Balfour Mount in 1974. He visited the St. Christopher's Hospice of Cicely Saunders, and he was very much impressed by the way these patients are taken care of. And he noticed that all these patients they are not getting cured, but they are protected from the suffering caused by the disease. So uh, these patients are getting are clogged or covered by effective symptom control. So he termed it palliative care. Pallium means to cloak, to cover. It's a Latin word. Pallium means to cloak, to cover. So it's a poetic expression that when you can't cure the disease, you cover and protect the patient with a blanket of effective symptom control through a comprehensive care. That's the meaning of palliative care. and essentially we aim at improving the quality of life of the patients. And we have to understand the concept of total pain. It is the concept was given by Dame Cicely Saunders. That is, pain has got a lot of components. Like there will be, of course, a physical pain caused by the injury of tissue or anything, and there will be a psychological pain, then will be social pain, then there will be spiritual pain. And all these components are interlinked and interdependent and mutually conditioning. And what the patient experience is a total pain. We have to understand that concept of total pain for effectively treating palliative care patients. And about the philosophy, everybody thinks that it's a charity work. Palliative care is charity work. No, it's not actually charity. There's an element of charity in it, of course, but we have to understand it as a human right issue, because the Human Rights Watch has said to leave a person in avoidable pain and suffering should be regarded as a serious breach of fundamental human rights. That is, by virtue of being a human being, I have an obligation to a fellow human being who is in suffering. I have an obligation to mitigate the suffering of a fellow human being. Sorry. And so that is the uh, uh, and so we have an obligation to mitigate the suffering of another fellow human being. So it's a uh, if we are not doing it, it's a violation of human rights. So whatever we are doing in palliative care is only re-establishing the human right of the patient. And one thing, I don't know how far this is relevant to volunteers, uh, is actually an experience of doctors who feel that they are potent, they are powerful, but all their powerfulness is lost when you encounter uh, some patients who are in apt misery, because slowly I learn about the importance of powerlessness. I experience it in my own life, and I live it in my work. The secret is not to be afraid of, not to run away. The dying knows that we are not God. All they ask is that we do not desert them. This is where Sheila Cassidy, she was working in Le Arche. It's a hospice, and she wrote a book uh, regarding the experience she had by traveling together the terminal patients. So at that time, she much of the problems we may not be able to address, uh, and in such situation, the patients know when the devastating illness like cancer is overpowering a human body like a occupied army, pillaging and desecrating the the body. They know that we are not God to watch it, but they only the thing they ask is that do not desert them. So in that situation, with your empty hand, yeah, can you sit with the patient and share his experience, that her experience? That is the question. So we have to be aware of our own powerlessness. And she has given that cartoon. Uh, as you can see, this is the in the first picture. The doctor is there, and he is having the nurse as an aide, and the patient is there. Everything, here is the clergy. The second picture is a clergy, and he also has his own uh, signs and uniform, etc. Everything is there, but slowly everything become irrelevant, and ultimately there is the picture of two nude human beings with empty hand. So what, what's the agent by which a palliative care worker treat a patient? It is not with it. Of course, we use medicines and everything, but maybe there is an element of the self as a therapeutic agent. So that's what I don't know how far it is relevant for a volunteer. But a doctor working in palliative care definitely will understand this situation of powerlessness. So, of course, we know that it was in 1967 that the first modern hospice was inaugurated, started, and it was only in 1987 that Royal College of Physicians in London recognized palliative medicine as a subspecialty of general internal medicine. So that was definitely there was a lot of jubilation on the part of those doctors working in palliative care, because they are all getting a recognition as specialists. But at that time, a dissenting note was written by Dr. Michael Kearney. Michael Kearney. The article came in Journal of Palliative Medicine, and he said, "I'm afraid we may be in the process of selling our soul to the very medical model whose excesses have created the needs our specialty sets out to meet." We have discussed earlier about the dehumanizing nature of the modern medicine. That is, reducing the patients into the person into patients and then to organs or tissues or disease processes. But palliative care is addressing the whole person care. And so it is not just another specialty. And another thing is that the potential for physicians working in palliative medicine to go beyond symptom control to creating conditions where healing at a deep personal level may occur for the individual patient. Why should we treat pain and other symptoms? It is not because pain is unpleasant. Of course, there is a reason. The unpleasantness of the pain is a reason to treat it. But beyond that, behind every pain, for that matter, any symptom, any suffering, there is an element of growth, a potential for growth for the patient, individual patient. So palliative physician has a role to uh, bring forth that uh, healing at the personal level to happen. So we cannot say that it's just another specialty. It's a specialty with a lot of other missions also. That's what Michael Kearney means. And we come to definition. And I have said palliative care, the concept of palliative care has undergone a lot of change during this course. The initial definition was that palliative care is the active total care of patients and their family at a time when the disease is no more responsive to curative treatment. That was the initial definition of palliative care. That is, it is relevant only when the disease is no more responsive to curative treatment. So we have this picture. We give anti-cancer treatment first, and when it fails, we go to the next component of palliative care. There is some injustice in this model, because the patient suffering starts on not only at the end of life, because the diagnosis of cancer itself is very devastating, and the patient will have a lot of problems even at that time. Uh, uh, there will be pain, there will be uh, psychological issues like anxiety, depression, and he will have apprehension about the disfigurement of his face and the oozing of the facial ulcer, and the uncleanness of his body, and how he has to face the society, how he is going to keep his grandchild in his lap. So a lot of, and there will be a lot of money spending. We know that 55 million people are pushed under poverty line because of the out of pocket spending in our country. So a lot of problems are there even at the beginning of the illness itself. But at that time, our medical the doctors know that he is having a lot of problems, but due to the disease focused approach, they do not consider these issues at all. They focus on the disease. Their agenda will be, what is this cancer like? Is it adenocarcinoma or squamous cell carcinoma, or what should we do, chemotherapy or radiotherapy, or surgery, or a course of radiation and then surgery. These are the issues come into the mind of the treating doctors. But at the same time, the patient is having a lot of other problems. But the treating team feel that when once the disease is cured, he will be relieved of all these symptoms. So he will be suffering a lot of misery throughout the course of the illness. And when once the disease is declined, no, is unrelieved, is incurable, then only the patient is shifted to palliative care. And when once they enter the palliative care, things are different, of course, because the unasked questions are asked. Who is the earning member of the family? How they are meeting the expenses, and how the children's educations are going. These sort of the beginning of the illness are asked only at the end of the disease. So uh, this is something which is there is injustice in it. So because these palliative care should be applied in the very beginning of the illness, and the outcome would have been much better. So this is another uh, model. Now, when the patient is diagnosed with the illness, there is a lot of scope for curative treatment, and this uh, shaded part is the curative treatment part. But and at that time, there is some palliative care also we can give, psychosocial support, symptom relief, etc. We can give, and as the disease progress, as the curative prospects decrease, palliative care component increase. The palliative care, we had to uh, increase the palliative care component. So towards the end of life, it will be only palliative care. And with the death of the patient, our duty is not over, because the family is there, and we have to give bereavement support to the family. That's also the duty of palliative care. So this sort of now the WHO has redefined the palliative care as palliative care is an approach that improves the quality of life for patients and their relatives facing the problems associated with life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. So now we are not waiting for the disease to be pronounced incurable. We had to uh, relieve the we had to relieve the suffering through early identification, impeccable assessment, and treatment of what is problem, physical, psychological, and social problems, and the spiritual problems. We had to address. Reason for that, because there's a study reported in New England Journal of Medicine. They gave only palliative care, only oncology, specific oncology treatment for the non-small cell lung cancer patients, and the other half of the patients, same non-small cell lung cancer patients, they gave palliative care along with oncology treatment, specific oncology treatment. Along with that, they gave palliative care also from the very beginning itself. And after a period, when they compared the two groups, the difference was very significant. There was those who received palliative care along with oncology treatment, they survived more. They survived average 3 months more than the other group, which did not get palliative care. And their quality of life was much higher than the other group. and the rate of depression was very less in the group that received palliative care, also along with oncology treatment. So now we know that palliative care is not something to be given at the end of life. No, it has to be given from the day one of the diagnosis of a terminal or long-term illness. So that we have to have idea, because the first definition, palliative is an active total care of patients and family at a time when the disease is no more responsive to curative, has been impressed in every mind. So even now people think that palliative care is something to be given at the end of life, when only when the disease is incurable. No, that concept has changed. Now palliative care has to be given from the day one of the diagnosis of a long-standing illness. And now we know that with the Lancet Commission report, now we know that palliative care has to be given for all patients who is having serious health-related suffering. So it need not be a terminal illness. It need not be life-limiting illness. But if there is suffering, the one factor that qualify a person for receiving palliative care is that he is having a serious health-related suffering. That's the only thing. So, to recapitulate, palliative care is an active total care, provide relief from pain and other symptoms, affirms life. We know that we are aware of the sanctity of life, etc., and so we affirm life. At the same time, we regard dying as a normal process, intends neither to hasten nor postpone death. We are interested in prolonging life, of course, but if in that process we are prolonging the dying process, there's no meaning in it. So we intend neither to hasten nor postpone death. It integrates psychological and spiritual aspects of patient care. It offers a support system to help patients and the family. It uses a team approach, because we need to have physicians, nurses, physiotherapists, uh, art therapists, music therapists, and volunteers who can make their life meaningful, can be accompanying their loneliness. So we have to have a very good team, and will enhance palliative care, enhance quality of life. And it is applicable early in the course of illness with other therapies that are intended to prolong life and include those investigations needed to better understand and manage distressing clinical complications. So this is the clinical scenario we are familiar with. They are acutely ill patient in the hospital. They usually get cured and back to normal, except perhaps for the added financial burden, which of course they can manage when their return to health. Then they go home and resume routine activities. This is the acute care setting. Our present day hospitals are meant for acute care, and our doctors are proficient in that also. But what happens to the patient who needs regular attention for the rest of his or her life? That cancer patient who was discharged incurable and sent home with a rise to feeding tube and all. What are his problems? What happens to the patient with incurable cancer after getting discharged? They are not relieved. They do have a lot of problems. Or the man who fell from the coconut tree and became paraplegic. You can just think about a person who is a coconut climber, just fell down from the coconut tree and taken to hospital. And in the initial phase, he will be getting all sort of treatment. And but when once the spinal cord transaction has been diagnosed and he became paraplegic, there will be nothing much to offer to him, and he will be sent home. And what are the problems he is facing? He has lost his job, and his life partner has become has assumed the role of a home nurse. A lot of losses there. And what about his sexual life? A lot of things are there. So he's having a lot of suffering, and we have to address that suffering. Or the man who, or the person with a major CVA. The initial phase of CVA, cerebrovascular accident, then stroke, etc. When a patient has stroke, he will be taken care of in the hospital in the initial period. And once the hemiplegia is set, one part of the body is paralyzed and he is sent back home, he will be having a lot of problems. But our conventional medical model, they feel that they have done everything for him. But actually, he is having a lot of problems, a lot of suffering, which has to be addressed. And for that, we have to have palliative care. Here comes the role of community, because many of the problems in advanced disease are of a non-medical nature. When you enlist all these problems, only uh, 20% of his problems will be addressed by medical fraternity, and the rest of the 80% problems has to be addressed by the community. The community has a major role to play in addressing these problems, and probably the involvement of the community determine the effectiveness of the medical intervention also. So because the suffering is total, the pain is total pain. So there is a psychological and social component, psychosocial issues are there. They can be addressed only by the community. So community has a major role, and there comes the role of volunteers also. The volunteers has a major role in addressing these uh, social issues of the patient. The patient may not have money to buy his provisions, and the volunteers can raise funds to meet that. They can see that the children's education are going on smoothly, or is there any problems with their education, or they can be just a company for them to mitigate the loneliness of the patient. So there is a lot of things the patient, the volunteers can do. They can organize palliative care unit itself. So we will come to that. And so for the chronically terminally ill, prone for crisis, service should be available 24 hours a day, 7 days a week. Because these patients are prone to have a lot of problems. Sometimes they will not be able to eat or drink properly, and they will have to have a feeding tube inserted. And then comes the patient may have retention of urine, difficulty to pass urine, and she may have to be catheterized. Urinary catheter should be installed, and after a few days, the catheter may get blocked, and we have to address that. And sometimes they start pressure sores start appearing, and we have to give some pressure reducing matters like airbud or something. And so a lot of these terminally chronically ill, uh, they have prone to crisis every time. So the importance that good quality services are available as close to home as possible. So this will be possible only if the help is available in the local community. So there comes the uh, role of community, and home-based rate. Home-based care is the backbone of palliative care, it is said. So it is possible to manage patients with advanced disease at home. People prefer to spend their last days at their own home. That's another reason. And home-based care is cost-effective. We know that there is a huge need for palliative care in our country, and we cannot afford to have all these patients to be cared at care facilities. But it's not cost-effective. Whereas when we care these patients at their own home, is very much cost-effective. And complications are less in home-based care with empowered partnership of the community. Infection, etc., are less when we take care of these patients in their own home. Of course, we have to empower them. This is a slide I prepared in a light vein, just a compare and contrast, more relevant for doctors. But it's interesting to have a look at the difference between the conventional mainstream medicine and palliative care. That is, in mainstream medicine, it is the ethos of military virtue of fighting, not giving up, endurance, hardness, and physician is the general, because the disease is taken as a threat from a foreign country invasion. So there, what we need is the ethos of military virtue of fighting, not giving up, endurance, hardness, and to lead the battle, we have the physician as the general. Whereas when you come into the palliative care, there is no meaning in that fight, because the white flag has already been there. And but there is one thing we are sure not to lose, that is the human dignity. This patient has a human dignity, and we have to take care of that human dignity, and that is the central value in palliative care. And there, the solidarity between the patient and the caregivers. There is no hierarchical model of caring team, that physician in the top, then the nurses, then the attenders, then the patient's family, and the society at large. That such a hierarchy is not there in palliative care. Everybody is in the same plane, and the patient is in the center, and patient is sovereign. That's the model of palliative care. And when you come to the mainstream medicine, is the physician is all powerful, because he has got a lot of information, lot of array of battery of investigations are there, and a lot of pharmacopoeia is there, and he feels powerful. But when you come to the palliative care, the physician knows the powerlessness, because at certain point, none of his manuals are going to benefit the patient, but he will have to take care of the patient with his own self, the self as a therapeutic agent. So in mainstream medicine, it is curing. You cure the illness. That's the thing. Curing means the disease is no more there. That is the curing. Whereas in palliative care, it is healing. You may not be able to cure the disease, but you must be able to heal the patient. When once you heal the patient, the disease is still there, but it doesn't cause suffering to the patient. And in mainstream medicine, the diseases are considered as seen as a problem to be solved. Each disease is a problem to be solved, whereas in palliative care, it's an experience to be lived. And how to make that experience livable, that is the question in palliative care. And when the patient dies, or in a cardiac arrest or something, in mainstream medicine, uh, the the attitude is, don't stand back, just do something. One person will be pouncing on the patient for cardiac resuscitation, another nurse will be drawing adrenaline to and another person wheeling the emergency trolley and intubating and everything. So doing everything, don't stand back, just do something. But when such a thing happens in palliative scenario, thing is not that, because there the long awaited demise of the patient is happening. So you have no right to tamper that. So don't just do something, you stand by. That's the attitude. And in mainstream medicine, death is always considered as a failure of treatment, whereas in palliative care, death is seen as inevitable reality. So that sort of thing. So in palliative care, we need a new way of seeing combined with a new way of acting. We are seeing the same patients, and the same pharmacopoeia, etc. are there, but we are seeing them with a new light, and we organize a new way of acting to address palliative care. So this is the comparison between two scenario. This is the acute care setting, where the patient's health condition is going on there, and there is a sudden dip and comes back and normal. he lives a normal life. Whereas in the palliative care scene, the patient's conditions steadily deteriorating and finally end up in his death. That's it. There will, of course, there will be sudden deterioration at times, sudden breathlessness or something, and taken to hospital and given injection and all, and it comes back, but not to the original level. One step behind, one step short, and another thing, suddenly he gets a diarrhea or something, became dehydrated, given IV fluids and all, resuscitated, but of course, a step lower. And this the health conditions steadily deteriorate and finally end up in death. So these two patients, the needs of these two patients are very different, and the skill for taking care of these two patients is very different. That is the palliative care scenario, and this is the usual hospital scenario. So the models of palliative care delivery. Uh, Am I going taking too much time? Do I have time?
Yes, sir. You have
Oh,
time. Yes, sir.
okay, thank you. So this is the we know that in Western countries it was hospices, but these hospices did not take root in Indian scenario because in 1983, 84 or so, that was the Shanti Avedan Ashram started in Mumbai, and within 2 years, the branches were started in Delhi and Goa. But by and large, not much of this hospice centers started in India. So there are two reasons. One is that the financial issue, and because starting a hospital and a hospice are same, because a lot of money has to be spent there, and we don't have enough money for meeting the needs of all the palliative care patients in our country. And another thing is that by culture, uh, uh, we we are not happy with sending our loved ones into a care facility when once they become very old, or when they have a lot of suffering. So a model which is suited to our financial and cultural situation is was started in 1994, 93. Actually, it is wrong. It is 1994, 93. Okay, it was 1993. Uh, and at that time, it was a great success. And the palliative circle world over were looking closely at this experiment. They were very happy that third world country like India is running a palliative care unit with the limited resources. So they scrutinized what is the factor that behind this success story. And the thing is that it was started by our own Dr. M.R. Rajagopal, who is heading the Pallium India. He was the anesthesiology professor at the Medical College Calicut at that time, and the concept of palliative care came into his mind, and he started the first palliative care facility in. I think this sort of palliative care facility in India as such, because and when he had planned to start a palliative care unit, uh, he was searching for a space, and he found out a space which was unutilized. There is a small room, and he cleaned that room and put a table and chair and started seeing patients. And that's it. So they are utilizing the existing infrastructure facility in a government hospital. That was the first factor that behind the success. They did not spend time, money and time to uh, purchase a land and build a building, etc., which are not going to materialize. So any government hospital, we can be able to see an unused space there. So we can utilize that infrastructure facility. And of course, a doctor alone cannot manage these patients. They need nursing staffs, attendants, etc. But he didn't get that personnel there. And their friends and their life partners came and uh, chip in and started helping the care of these patients. That is the next factor, that is filling the gaps with volunteers in the community and empower the family. Much of this work we are doing in hospital can be done in their own home if they are taught how to do these things. So that is the empowerment of the family and partnership with the patient and family. And many of the make them partners in the care process. That's that was the factor that was behind the success story of Calicut model. And then came the neighborhood network in palliative care. When the Calicut team started their outreach centers in Malappuram district, which is a nearby district of Calicut, there the volunteers, the general population, they were much interested in this sort of activities, taking care of patients and all. So they took more initiative and they started uh, identifying patients who are in need of palliative care. That changed the whole color and texture of palliative care, because when in Calicut it was essentially a professional led program. So the doctors, when they identify patients, they have their own professional bias. Oh, this patient is having lung cancer, he needs palliative care. This patient is only having asthma, bronchial asthma, or chronic obstructive pulmonary disease. He will need, he doesn't need palliative care. Actually, there is no much difference between the suffering of these two group of patients. And when lay people, the volunteers, uh, identify patients, they identify patients not on the basis of disease, but on the basis of suffering. So they started enrolling chronic respiratory disease patients, chronic cardiovascular disease patients, psychiatric patients, then chronic kidney disease patients, liver disease patients, etc. And the extent of palliative care was enlarged. And they also started to lead the palliative care project, and they have the ownership, the that the local people became the owners of the palliative care unit. So that contributed to the sustainability of the program. So what this neighborhood network in palliative care is the empowerment of local community to look after the bedridden patients in their area. So we are empowering the local community and to develop a cost-effective method for the provision of palliative care in our settings. So essentially, neighborhood network means it's a network of trained volunteers in the community. We give structured training for these volunteers who are interested in taking care of the bedridden patients in their neighborhood. And these, there will be a support system by trained professionals, institutions, and organizations to help these volunteers. So this is essentially the neighborhood network in palliative care program. This is a step forward from the initial Calicut model, which made our community-based palliative care program successful. And actually, this was very much uh, acknowledged. This community approach in palliative care, 28 years after Alma Ata, shows the way forward for palliative care for all. If similar strategies can be employed elsewhere, that would be a very important step forward for global palliative care. This was written in the Journal of Public Health Policy, 2007. And in Kerala, we have a palliative care policy established in 2008. And before that policy, essentially palliative care has been done by community-based organizations with their voluntary work as a voluntary work. So the palliative care policy envisaged including the CBs also into the palliative care delivery. So the palliative care policy envisaged palliative care delivery, the palliative policy envisaged palliative care delivery as a joint venture of community-based organizations, local self-government agencies, and local government healthcare institutions. So all these things has to be. So the voluntarism of the community-based organization is maintained. And at the same time, the large machinery of government agency is also incorporated. So we have a model where government and non-government agencies join hand in hand and work for the mitigating the suffering of the patients. So this is a public health approach. The care in the community by volunteers take the major share of healthcare. That's the prevention, early detection, and management, etc., are taken care of in the community by volunteers. And whatever that palliative care needs, which has to be met by health professionals, that will be taken care of in the primary healthcare, community-based community healthcare, etc., CHC, PHC, etc. They are supposed to be the secondary care units, and only those patients who cannot be taken care of in this primary healthcare, then they only is taken care of in the specialist care by district headquarters hospital or medical college, palliative care unit, etc. This is the public health approach to palliative care. Now about recognized medical institution. This is an attempt to make opioids available to the needy, because there in 1984 or so, the Narcotic and Psychotropic Drug Substance Act was a draconian law that made opioid availability almost impossible. So then the Supreme Court intervened and directed every state to amend the Narcotic and Psychotropic Substance Act, and as usual, it was Kerala government that first of all made the amendment. And according to the new Narcotic and Psychotropic Substance Act, if a drugs controller recognizes a palliative care unit as recognized medical institution, they can directly purchase oral morphine from the manufacturer, store and dispense. Before that, it was under the control of excise department. So and the legal procedure was very elaborate, and the penalization is also very stringent. And so now we have a very simple procedure. If a drug controller recognizes a institution as recognized medical institution, that can directly purchase more morphine, store and dispense. And the criteria for recognizing a institution as recognized medical institution is very simple. A doctor with minimum 10 days hands-on training in palliative care for a recognized training from a recognized training center. That is the essential part of RMI. That is a doctor with minimum 10 days hands-on training, and a double locking facility for storage of oral morphine, and the basic infrastructure facility for care of the patients. When the drug controller is satisfied with these things, he will get that insurance. When once we get that certificate, can purchase oral morphine. So these are the things I wanted to share to it.
Thank you so much, sir. Thank you for sharing such a wonderful insight on palliative care. Hope all have understood what palliative care is, who should be given palliative care, when it should start, and what all are the aspects that should be addressed in palliative care. Also, he had briefed about the role of volunteers also. So hope you all understood. If you have any queries, please post it on the chat box, or maybe you can raise your hands. We shall address that query. Anybody who wants to ask anything? So we have a question in our chat box. To start a palliative care unit in hospital, RMI process is the same.
No, the palliative care unit need not be an RMI. RMI is only for purchasing oral morphine. Providing oral morphine is one aspect of palliative care only. You can do a lot of other things in a palliative care unit. You can give psychosocial support. You can give all sort of analgesic except morphine. Of course, there is a big role for morphine, but just because you don't have morphine, you need not stop. You need not deter from starting a palliative care unit. Of course, if you have morphine, that's a great thing because you can give pain relief to these patients. But apart from that, you can do a lot of things. You can have a home care unit. You can give psychosocial support. You can give all medicines except morphine. So to start a palliative care unit, you need not be a recognized medical institution.
Also, I would like to add, if you're working in a government organization, you are a deemed RMI.
Sorry?
No, I was just adding, sir, if they are working in a government medical, government organization, government hospital, it's already a medical, like it's already a recognized RMI institute. So
no, but in Kerala, it's not like that.
Okay.
The government institution also has to be to become a recognized medical institution. That I have gone for inspection of these government hospitals and medical colleges, and when the drug controller is satisfied that there is a doctor who has undergone this sufficient training in palliative medicine, then only they will be given RMI status.
Okay. Okay. Thank you, sir. That's a new input for me. Thank you. Saumi Khan has a query. Please explain the term hospice.
Good evening. Sir, please explain the term hospice. Actually, due to network issues, not what it is.
Of course, hospices are institutions where patients who have life expectancy less than 6 months are taken care of. Actually, hospices are not the building. Actually, it's a care philosophy. It's taking the patient as a person and addressing the whole suffering, physical, social, psychological, and spiritual. That sort of a whole person care is the places where that sort of whole person care is given. They are called hospices. But essentially, the life-limiting the patients with life-limiting condition are only admitted in hospices. So hospice care is, of course, palliative care, but all palliative care not hospice care.
Thank you, sir.
Thank you, sir. There is another question by Sarita. Do we have any assignments? No, I don't think so. If you are, if there is anything, the training team will get back to you. Okay. Another query is, who all can do palliative care course? It's from
palliative care course can be done at several levels. On an as a level of a volunteer, as we are doing now, we can do a lot of things for the patient. So how to empower ourselves for addressing the social, psychosocial issues of the patient. That's what we are supposed to understand. And when once, if it's a doctor, the doctor needs to understand the therapeutic approaches to mitigate the suffering through pharmacological means, etc. And pharmacological and non-pharmacological methods of addressing the suffering of the patient. That needs that's the basic minimum training is 10 days hands-on training for these doctors, and we have another 6 weeks basic certificate course in palliative medicine, and we have now MD program in palliative medicine in selected universities, hospitals.
Okay. There is a reply from Dr. Divakaran also. Whoever compassionate and think out of the box can do palliative care course. So there is something a reply from Dr. Kiran. Okay. Next is please share the PPT to our emails. Yes, we'll be sharing the PPTs through emails. Also the recording with you. The training team will do that. Another question is, sir, what if we attach the process of palliative care with the connecting with nature, like natural healing? It's from Samiran Karki.
Samiran Karki.
Yeah.
There's a lot of alternative treatment programs apart from the modern medicine. As a modern medicine doctor, I don't know anything about the other systems of medicine, but as we are working in palliative medicine, we open the door for any other systems of medicine. If the particular patient is patient wants to explore the possibility in another system, of course we say we can try, but we insist that one or two things. One is that if it is too expensive, please don't go for that, because we have lesser expensive options here. Another thing is that if that system wants rigorous dietary restrictions and all, then we'll say don't go for that. Otherwise, we are open to all other systems.
Yeah. Thank you, sir. Satya Sai Sri Lakshmi has a question. Is this training enough to be a volunteer in palliative care center? Should we do further trainings? Any suggestions?
I don't know what are the components of this training program. Ideally, it should have a practical component also. That is, when we do at the Institute of Palliative Care in Thrissur, we continue this theory session with 1 day experience in the clinic and 1 day experience with the home care team. So that only completes the training program. I think there will be some provision there also.
Sir, in the online training program, we don't have a provision for hands-on exposure, but we do have a 3-day training, volunteer training program at Pallium India, which is a on-site training program. There we'll have a hands-on exposure. Like we'll be sending you for a home care. Like it is a 3-day program, so 2-day on-site lectures, and on 1 day will be the home care. So that would be.
I think Pallium India has a lot of collaborating centers throughout India.
Yes, sir.
So I think we can delegate these volunteers, the trainees into particular centers there, and attach them to the nearby center and do the.
Yes, sir. We can opt that option too. Satya Sai, I wanted to ask you, where do you belong from? Which state?
Andhra Pradesh.
Puttaparthi.
Andhra Pradesh.
Okay, okay. We'll share the hands-on training partners that we have there with you. So the training team will do that. You can go to any of those centers and go for home care with them.
Okay.
Actually, that was those centers were actually they signed the hands-on experience partnership with us for the online courses that we do for the doctors, nurses, and all. So for volunteers, we'll have to check if they allow for 1 day or 2 days. We'll check with them and then let you know. The training team will get back on that to you.
Okay. Thank you. Thank you.
Most welcome. There is another question, sir. What is the difference between palliative care and hospices?
I think I have explained that palliative care is something to address the suffering, and it starts on the day one of the diagnosis of a long-term illness or serious illness. But whereas hospice is towards the end of life, because the patients who have less than 6 months survival, they are only taken for hospice care. So essentially, hospice care is palliative care, but all palliative care is not hospice care.
Is there anything that you wanted to understand? The query was from Deccan Tamang. You had raised your hand also. Is there anything else that you want to understand?
I think you had to understand they learn lot of things. I don't know how far this sort of a online training can cover all aspects of palliative care, but anyway, this is a very good starting point, and you want to understand the role of social workers in palliative setting.
That's another question, sir. What is the role of social workers in palliative setting?
Yeah, they can give psychosocial support to the patients, and they can organize means to meet the provisions required for the patients, because the patient is maybe the patient might have been the breadwinner of the family, and so when the breadwinner of the family income will be stopped.
Sorry, sir, we lost you. I think we lost him. Sorry, sir, we lost you in between. We couldn't hear you in the last minute.
As a social worker, we can do a lot of things. We can give psychosocial support to the patient. We can be a company for the patient. We can be a company in their loneliness. We can alleviate the fear of the patient. We can have spiritual care of the patient. We can have practical help to the patient by providing the provision, addressing the educational requirement of the children, etc. A lot of things can be done by social workers.
Thank you, sir. There are a few queries on hands-on training. So the training team will be sharing the list of hands-on training centers that we have signed agreement with. So you might have a group, a WhatsApp group or email group. The training team will be sending the details into that after the program ends. So it's a 5-day program. So on the last date, the training team will be sharing the details. Bangalore, we have hands-on partners. In Mumbai, we have hands-on partners. Sarita will be attaching you with any nearby center for your experience. So in almost in all states, we have hands-on partners. So we'll be sharing that list with you. We have almost 54 sites as on date. So we'll be sharing that with you. Any other queries? Anybody else? Who Okay, I think we are done, sir. So thank you so much, Divakaran sir, for taking out your time and introducing to us to the palliative care. This team to the palliative care. What you call the world. Thank you so much, and thank you all for joining in. We'll be keeping in touch with you with the regular updates on the program. So see you tomorrow at same time with another session. Thank you so much.
Thank you. Thank you very much.
Thank you, everyone.
Yeah, thank you very much, sir. Yeah, it's of great. Everyone.
Thank you, sir.
Thank you, sir.
Thank you. Thank you.
Sir.
Thank you.